I'll MC us tonight. I'm Dr. Lauren Young. I'm a naturopathic physician here in Manchester and medical staff with ECHN, which I'm super proud about. And
I'm Dr. Rubino. I'm a general surgeon here at Manchester Hospital, and I primarily focus on breast and breast health. So I work with Dr. Young and with Donna for our patients who come to Manchester Hospital.
Hi, good evening, everyone. My name is Donna Cameron. I'm the Director of Oncology and Women's Services for ECHN. I am a nurse. My passion has always been women's health, especially breast health. So I'm very excited to be here tonight with Dr. Rubino and Dr. Young to take this nice holistic approach to talking about breast cancer with you all today.
So most important is that you maintain a healthy lifestyle for breast health. And people sometimes have different interests and concerns about what their lifestyle should or shouldn't be. But what we would think and what statistics and research has shown us is if you limit some of the things in the regular diet that people have, including alcohol, sometimes caffeine can make a difference, and salt, it would help to make breast health optimized. The other things that are very important are to stay active. And that what we have found is if you do 30 minutes of sustained exercise 3 times a week, that is very helpful for people who have no breast disease and for people who have actually had breast cancer, because they do better. So I always thought that I was very active in my office and I'm always doing something and moving around, but 30 minutes of sustained activity sometimes is hard to meet. So it's something to incorporate into your life. And we find that statistically has made a big difference. The controlling your weight is, I know, a difficult and sometimes sensitive factor, but the thing to remember is that there's hormones inside of fat, and people who have an overweight composition have more hormones in their body than the person who's the average weight for their same height. And that can contribute to what we think of as a risk for breast cancer. So that's why weight is concerning for people who have a predisposition to breast cancer. Lastly, I think, and it's listed here as the first thing, is the family history. And it's very important to know your family history. And sometimes now people, don't always talk about their family history, but people are becoming more aware of how important that is to their lives, just because it gives us an idea of where you stand in a risk pool. So let's see what the next. Okay, so there's lots of controversies about performing self-breast examinations. And I know that people get very concerned about what they're finding and what they're feeling, but you need a professional once a year doing a breast exam on you. And if they highlight things after that exam, like these are areas to be concerned about, or these are areas that are normal, that's what to keep in mind, because we don't expect you to diagnose what you have. It's just to tell us that there's something different in your breast exam. So if you get used to what your breasts feel like, then you can say, this feels different than the way it did 6 months ago or a month ago. So that's what I always talk to patients about as far as self-breast exams. And don't worry about telling me whether it's accurate or not accurate, because it's just important that you bring it up to somebody. And there's never a wasted visit with somebody who comes in and says, I don't know what I'm feeling. I'm not sure if this is normal. It doesn't matter. You just need to bring it up so that we can take a look and decide if there is more that we want to do. The clinical breast exams that people talk about are the ones that are done by a professional, and you need one professional once a year at least doing a breast exam. The mammograms after 40 are the recommendations. Certainly if you sit in one of the risk pools, you might be starting that a little bit earlier. And then mammogram and ultrasound is very helpful for people with dense breast tissue. The risk factors that you're not going to be able to adjust or make different are, of course, the age, the genetics that you're born with, your reproductive history. And I have a funny story about that. I have my children when I was close to 40, and my children told me that they weren't going to do it like I did it. And now they're past 30 and still have no children. So I always tell them, like, you know, never say never, and you never know when you're going to be able to fulfill that that need of having children. So reproductive history is sometimes just not something that we have a lot of control over. Having dense breast tissue can put you at risk, and then again, the personal and family history. We don't see this as much as we used to, but at one time there was a big push for people who had thyroid cancers or thyroid disease, or sometimes even acne, to get radiation therapy. And it's kind of fallen out of the wayside, or they cone in more on the thyroid, but there is a certain portion of the population that did have what we call mantle radiation, which is like from the nipples up to the neck, and that can put you at risk for breast cancer as well. So the things that we can change that we talked about are the physical activity, the weight, taking hormones, which is usually something that we see postmenopausal women more apt to do in regard to avoiding some of the side effects of menopause. And then, of course, the drinking alcohol. And the breast examinations, the clinical breast examinations by a professional, and then your breast anatomy are the things to just be aware of. And I usually hand out a book to people who come to see me about what the anatomy of your breast is, so you understand what lobules, ducts, nipples, how they all relate, what we are looking for, and why certain things are more obvious on a mammogram and certain things are more obvious on an ultrasound. Next. So this is your anatomy. The thing, so those pink lobules on the outside with the fat in the background are what make the milk. As you lead from those down toward the nipple, you'll see these purplish color areas, and those are the ducts. So 80% of breast cancers occur in the ducts, and about 15% occur in the lobules. And then these cone down into where the nipple is. So this is your anatomy. As you get older, these lobules of breast tissues contract because they atrophy from not having hormonal stimulation. So you see the breast more filled with fat than you see filled with the lobules of breast tissue. Okay, next. There's precancerous changes that now we are much more aggressive about treating, and we actually treat them as, at least for the ductal carcinoma in situ, we treat it as a cancer, not because we know that it's going to turn into a cancer, because we don't know that. There have been studies on cadavers that they'll find ductal carcinoma in situ in patients, and they never had developed a cancer, but we know that this is a risk. So we consider ductal carcinoma in situ, which means that the cancer is in the duct, it has not gone past the duct, or lobular carcinoma in situ, which is the same thing, but in the lobule of breast tissue. These things put the patient at risk to develop a breast cancer. It's about 1% per year. So if you had someone who had a biopsy at the age of 86 or so, and they had DCIS, their risk for developing what we consider breast cancer, or what we call in the medical field invasive breast cancer, is about 1% per year. So this is the ductal carcinoma in situ, the first one. Sometimes they're seen on mammograms and they can appear as calcifications They are, I get about 20 to 25% of the cancers that are now being diagnosed, and the cure rate is nearly 100%. So in the 80s, we didn't know what to do with microcalcifications, so we weren't sure whether to biopsy them or not. We're much more aggressive about biopsying the microcalcifications. And when we do find DCIS, it's very easy to treat. And because it's still contained within the duct of that area, you don't have to check the lymph nodes. So the cure rate, as they say, is very high. As I said, the in situ means it hasn't invaded past the duct or the lymph or the tissues or gone into the lymph nodes. It's usually treated by removal of that area, a partial mastectomy or lumpectomy, and sometimes radiation. And that determination depends on other tests that we will do postoperatively to see what your recurrence rate is. So radiation is a possibility. So this is showing a mammogram, I think it's an MRI, yeah, MRI of a breast. And the white area down lower is the area of the DCIS seen on an MRI. Lobular carcinoma, or LCIS, is commonly found in premenopausal women. It's not usually seen on a mammogram or an ultrasound, and it's usually diagnosed inadvertently. So it's found when we take out a mass on some patient who has a benign breast mass, and they'll say, you have LCIS associated with that mass. And we don't, as I say, we don't really have a screening tool for LCIS at this time. So what is breast cancer? It's breast cells that have started to reproduce abnormally, and they grow into the tissue of where all your breast tissue can be. So it'll start in one area and it can spread to all the other areas where the breast tissue is. And then once it goes usually past a certain point, it can invade lymph nodes, it can invade blood cells or blood vessels, and the surrounding tissue, including skin. So women in the United States get breast cancer more than any other type of cancer, except for skin cancer. And it's second to lung cancer as the cause of death in women in the United States. So each year, about, as it says, 200,000 women are diagnosed with breast cancer. More than 40,000 will die this year. Approximately 1,700 men will be diagnosed with breast cancer, and about 450 will die. Unfortunately for men, many times they don't bring up the fact that they have a chest wall mass. It's sometimes embarrassing. They don't like the testing, which is, again, a mammogram for a man, which is difficult. So sometimes the delay in the diagnosis is what makes their outcomes worse than they are for females, because females more likely will pursue a diagnosis and some treatment. So each year, each year, we have that already. We went over that, yeah. So breast cancers begin in the cells that line the ducts in ductal cancer, and then the 15% that begin in the lobules of the breast are a much smaller number than the ductal cancers. So after we get through what the breast cancer and the different types that you can have, the other thing that has come to into the limelight is the genetic portion of breast cancer. Unfortunately, this is a very small amount of people who have breast cancer, but we screen people with certain risk factors to see if they can possibly have a BRCA gene. And a BRCA gene can be determined by sending it out for evaluation. And if they do have a BRCA1 or a BRCA2 gene, we know that their risk for developing a breast cancer and or an ovarian cancer is very high. So the blood sample is what is required. We now are able to do what we call a spit test. So you can also do it with a spit sample and send it in to get a genetic profile. And then the test enables you and your family to know what risks you have and what your family has. So if somebody did test BRCA positive, we would then go on to recommend that their family get tested. And with that, once we know where the gene abnormality is, we can hone down on that gene for the subsequent family members, which makes it even a better test because we know exactly where to look. The other types of variables that are included with breast cancer there are sometimes on breast cancers a protein or a receptor that are on the outside of one of the cancer cells. With that, you can test for those receptors or proteins. And if they're positive, we have medications that you can take by just using a pill that would cut the risk almost in half of developing a recurrence. So somebody who has a breast cancer and has an estrogen or progesterone receptor on their breast cancer, which all breast cancers are tested for, would then go on to use a pill to help to control the recurrence rate of this cancer. And the same thing for HER2. HER2 is a protein that we would look for to see if we could control that with a pill instead of, necessarily going through a lot of chemotherapy or other types of treatments. So the thing to remember is we don't have a lot of control over what we are born with, but we do have a lot of control in the way we live. So a healthy lifestyle, being aware of what your family history is, doing self-breast examinations in case there is something that you need to know about your breast and bringing it up to somebody, having your physician do a breast examination, and then having regular screening tests are the only way that we know right now of how to treat people and how to take care of them. So we unfortunately don't have a test that we draw some blood and say, oh, you're going to get it and you're not going to get it, except for the genetic types of tests. But these are the things that we can do now. And I'm sure as in the future, we will have more things that we can do, which will help us to determine how to treat people and the risk that they have.
As a naturopathic physician, I love everything they were just talking about, like as far as lifestyle, right? Like that's kind of my jam is using like your food and lifestyle, exercise as medicine. So where does this play a role when it comes to treatment and oncology and in breast cancer? So certainly like I'm going to be supporting the same kind of screening guidelines and those things as well. But helping, if you have a family history, like other ways to get your lifestyle in a good spot, if you were looking at improving your body composition, those type of things as prevention can definitely play a role. But then if there is a diagnosis, it doesn't have to be an either or situation. You can still be working on your lifestyle. You can still be working on your body composition and your strength in your body throughout the treatment and active even afterward, once you're in remission with any kind of cancer. So our goals while we're in treatment would be to make sure you don't have any drug or interactions or supplements. A lot of people take supplements. Many people don't tell their doctor about them because they don't want to get told not to take them. In one study, they found Cancer Treatment Centers of America is these private hospitals that are basically naturopaths are in the hospital with oncology, and they specialize in oncology. They found that 25% of the people coming into the hospital had some type of drug herb interaction. So they were taking a supplement that was negatively impacting their medication or negatively impacting their body. So there are a lot of drug herb interactions, and that's something to be very careful with. I wouldn't recommend just taking something off of the shelf at the health food store or buying it off online without running it by a physician who knows the interactions. We also want to improve quality of life through treatment, minimizing side effects while enhancing the treatment itself. There's a lot of research that certain lifestyle choices, dietary things you can do can actually make treatment more effective, so that you only have to go through treatment for a short amount of time and you get through it really well. One of the myths is that like just powering through side effects, but side effects sometimes, and Donna and Dr. Rubinom can speak to this, like they limit treatment sometimes, because if your white blood cell count gets too low or you're too weak, you can't go through treatment. There are things that we know are evidence-based. There's studies showing that you do these certain things and it'll make your treatments more effective and less side effects. So those are the type of things we're looking at to keep you really strong. So again, use of dietary supplements can be awesome. And obviously I'm a big fan of enhancing your diet with supplementation when appropriate and evidence-based, but it can also be a big problem. And naturopathic physicians are trained in this type of medicine. Lots of examples of using certain things, like in this case, using alpha lipoic acid with this particular medication reduced the risks of neuropathy, which is a really common side effect with a lot of different chemotherapies. Another example of turmeric potentiating the use of the medication and being able to tolerate a steroid therapy better, which may be necessary for certain medications. And so going back to like the tenets of health, making sure you're sleeping well, you're eating well, you're like all the good things, supporting the whole person is really one of the important things is comprehensive oncology care. And so that means like, how are you doing as far as pain? How are you doing as far as sleep? Are you feeling like you're socializing enough? That is a big piece of it. And there's so many aspects of this that, tapping into your nurse navigator or with a naturopathic physician or a dietitian or a PT through your treatment can be very beneficial at making sure you're addressing all the different aspects of you, which is a big part of getting through this treatment. And then obviously maintaining remission is definitely something we're going to be looking at. So they found that there's a lot of research in supporting your immune system, improving your body composition and things like that to be able to help keep you cancer free once we've gotten you on the other side of treatment. One of my big passions and the reason I do so many lectures with ECHN is the research around locus of control. So this is a very important thing, regardless of what kind of cancer you're going through or health condition in general. One of the best researched concepts in medicine is a locus of control, or where do you perceive the driving force in your life? And if you feel empowered, whether it's diabetes or it's cancer or it's an autoimmune disease, you will have a better outcome with your health condition. It's been studied across so many different, it's like Freud, Jung, and then Rotter, the founder of this research on locus of control. So if you feel empowered with your health, you will be healthier. Think about how powerful that is. And so I think having a team to support you, to help you feel in control, that you understand the treatments, you understand what you're doing with your body, you understand how to feel empowered around all this, that alone is therapeutic. And that's one of my big goals when it comes to naturopathic medicine, is kind of the concept is docere, or doctor is teacher. And my goal is that you understand your body and you feel like you understand your treatment and you feel good about it, because that will impact your outcomes. So we're going to hammer it on every front, right, guys? Like healthy lifestyle is key. And I'm going to say also feeling emotionally and connected to your community, stress reduction, breath work is going to be a huge field that comes down the pike as far as being able to calm down your nervous system, boost your immune system, the rest of it. I think it's going to be just as important as exercise, honestly. As we research it, it's really powerful. So making sure you're treating your whole person and not just, powering through surgery and radiation. So what's the right diet, right? That's what I get told a lot. and I just wanted to kind of like nip it in the bud and go, okay, like, so there are, I have people coming in, they're going to be raw food vegan. I have other ones that are going to be vegetarian, they're going to be paleo, they're going to go keto. When it comes to cancer, what we know is really processed, and especially ultra processed, which is like the stuff where it has more ingredients that you can't pronounce than actual food. That is a big risk factor when it comes to cancer. So like, salty certainly goes along with that, same like Dr. Rubino said, but it's that ultra processed food. I mean, guys, look at some of these ingredient names, and we see them on our foods, right? So that ultra processed stuff oftentimes is in a container that is also potentially ultra processed. So bisphenol A was found in baby bottles for a long time, and it basically mimics estrogen in the body. It's been pretty much taken out of most of our plastics, except for it lines a lot of cans. So if you're having an ultra processed food that's canned and lined with bisphenol A, you're getting a lot of burden on your body that's going to have to deal with it. And what we've seen is that that is connected to cancer risk. Another thing is, I know, and I loved how Dr. Rubino said it, like there's no judgment around weight, but at the same time, there is risk with body composition and cancer. And it's because, again, adipose tissue doesn't just hang out there, it's inflammatory. It hoards a lot of chemicals, a lot of fat soluble chemicals that are not great for us. It throws our hormones off because it upregulates certain less healthy estrogen metabolites and other hormones. So we want to make sure we're focusing on building muscle and decreasing adipose tissue through all of this. And these are all the connections with all the different types of cancers. Again, it's not necessarily just weight, it's about building muscle and feeling strong. And so it's there are a lot of people where their BMI does not reflect their muscle. And so I'm not worried about the scale as much as I'm worried about percent body fat and feeling strong in your body. It is hard to make these changes, and there's a lot of emotions that go around the diagnosis of cancer, and like guilt or shame or fear, right? There's a lot of stuff comes up, and so it's really important to know that you got to take this stuff one step at a time. That this stuff happens, like we said, there's so many variables that impact us that have nothing to do with our control. So you do one step at a time, and they call them SMART goals, right? So they're specific, measurable, attainable, relevant, time-based. So we all know we should exercise more. We all know tomorrow night's Friday, we shouldn't be eating pizza. And yet a lot of us will not exercise tomorrow, and we will probably, a lot of us eat pizza. And that's because of stress and a lot of other things, patterns, lifestyle. There's so much going on. So working with someone, picking small measurable goals that you can step your way towards better lifestyle habits is a great way to kind of approach it. And I think it's one of those things, we all know we should eat more vegetables. We all should know we should eat less processed food. Picking goals to move towards that is really the key. So I see a naturopath, or honestly, you can pick other people in your care team that can do this: nurse navigators, PTs, OTs, whoever else is in your team, a therapist. Someone else is there is like to keep you feeling empowered and helping you kind of bounce your ideas off it, holding you accountable and keeping you focused on improving your wellness. Other things that ECHN offers, and I think are really, ECHN offers massage and acupuncture. I also think there is research for a lot of different modalities, including intravenous vitamins. There's research on some of these things helping. I'm missing a slide, but you guys get it. There's a lot of different other integrative therapies that have research to helping you get through treatment and feeling strong and out of pain and your most vital self. And so, especially when you're going through something as intense as this kind of treatment, having a modality where you get to just show up and have someone take care of you is really a great thing. And so I highly recommend, seeing what resources are out there. Talk to your nurse navigator, your team, and say, like, what do you think would be good for me as far as boosting my immune system, helping me feel less stressed, helping my sleep get better, those type of things.
Some really important areas that that you both mentioned today, and one of them is, you know, as Dr. Rubinom said, taking care of yourself. I mean, you are your own best advocate. You know your body. You know, use that yearly exam, whether you're going to see a OBG, your primary care provider, if you've had surgery in the past and you're following up with a surgeon such as Dr. Rubinom, make some notes. You know, if you've done a clinical breast exam or you've known some changes, you've done a self-breast exam or you've noticed some changes in your breast, because a lot of women, when I talk to women in the community and they say, okay, so I'm just going to, you know, feel around that little breast there, just that little circle of area there, that's my breast. That's where, no, see that thing that's called a clavicle way up there. You're going to start way up there. See the thing area that says the axillary lymph nodes under your arm and your armpit. You're going to be going all the way. That little center there, that sternum or the breastbone, consider that the dividing line between one side and the other side. So focus on that other side. You can actually go up and down all the way up to the clavicle, almost like you're mowing the lawn. I'm a person that likes to put little descriptions in here. So, you know, you're just going to go up to the top there and feel, how does that feel? Many women have lumps and bumps in their breast, especially young women will have many lumps and bumps in their breast. I call them BBs, busy breasts. So you may be somebody who's got BBs, very busy breasts. Know your lumps and bumps, know where they are. If you're a young woman who's still having her period, check your breasts about 3 to 5 days after your period starts. If you're into menopause already, find a date that works for you. I like the number 15. That's going to be the 15th of them every month. I'm going to check my girls. Know my girls. Know your lumps and bumps. Know your breasts. Because then if you find something and it's like, oh, this feels a little different than what I felt before, make a circle, dot in the middle, X marks the spot, give that information to your provider, because 10 to 1, you're going to forget where it was when you felt it. And when you get to your provider, you're going to say, I don't know, maybe it was here, maybe it was here. X marks the spot. You can bring that information to your provider. Another interesting thing that Dr. Rubinom said is, we talked about family history. Thanksgiving. We all get together pretty much at Thanksgiving, whether it's virtually or in person or both. Make that the day that you share family history. I am a strong proponent of there should be no secrets in family. You should know your family history. You know, everything should be out there on the table. As Dr. Rubinom said, that's a small piece of what, when we find women that are diagnosed, only about 15% to 20% of it is due to family history. Genetics, Dr. Rubinom talked about heredity and genetics. Again, knowing your family history and genetics, that's only 5 to 10%. So there's a huge piece of that pie, 70 to 80%. We don't know why a woman has developed breast cancer. So that's why those other things that Dr. Rubinom and Dr. Young spoke about being active, and that 30 minutes is tough, especially when you work. But try to get that 30 minutes in. Start maybe simple, 15 minutes, 10 minutes, 15 minutes, and build. If you're watching TV, get up during the commercials, march around a little bit. I've heard people say to me, Donna, it's the wintertime, I hate walking upstairs. Do you work in an office when there's stairs? Go up and down the stairs during lunchtime a few times. Boy, is that a good cardiac workout, going up and down the stairs a few times. You know, as Dr. Young said, make short goals for yourself. Don't overwhelm yourself, because you won't do it. Short, sweet goals. Alcohol, yes, that little glass of wine at dinner is wonderful sometimes, but it's empty calories, it's sugars, it can lead to obesity, the processed foods that you've talked about. Looking at labels too, you'll look at a label and you're thinking, oh, I'm buying something great. It says it's low fat or low sodium, but is it now high in sugar? So there's so many times there's a trade-off in regards to one for the other. So just be aware of that. If you're concerned about how, I don't know what to do for a diet, go to Google My Plate. It's a great little thing. It's an interactive tool. It can give you some great information to help you to get jump started in regards to what you want to do. Dr. Rubinom also talked about getting your mammograms done. Really important. I know women don't like to get those done, but easy breezy things to do. Get it done. Doesn't take long. We have the Women's Center for Wellness. We offer at Rockville, Manchester Hospital. We get women. I navigate women from teleimaging as well. But again, know your family history so you can talk to your doctor. The recommended age is to start at 40, but sometimes it's good to talk to your doctor, know your family history, and do a risk assessment. Maybe some of those things that Dr. Rubinom talked about. Maybe you've got a first-degree relative that was diagnosed with breast cancer before the age of 50. Maybe, I've met recently with a woman where her mom was diagnosed in her 30s. And it's like, you're now raised the bar. That's a first-degree relative. We've now raised the bar for you. Those are important things that your provider needs to know. Doesn't mean that things are going to happen to you in the future, but it means we can put a surveillance plan into place for you. So maybe you're going to start your mammogram sooner than 40. Maybe we're going to do a mammogram, an ultrasound, and throw in an MRI. It's like a Chinese menu here. We're just going to pick whatever it is that we need to do to be able to stay on top of your breast health. Let's see, one good positive thing to know is there are 4 million survivors of breast cancer in the country. So we must be doing something right here to get women screened, to really push this, everything that we need to do, because we have 4 million survivors in this country and it's only growing. Dr. Rubinom talked about getting an ultrasound dense breast density. Most places have a patient portal, so your breast imaging report is going to go on a patient portal. It can be very confusing to read those reports. I actually had a woman one time call me and she says, Donna, don't laugh at me. And I'm going, no judgment zone here. What's up? She goes, my report says I'm dense. I know I'm blonde. She goes, I know I'm blonde, but they're calling me dense. And I said, please, with all due respect, we're not calling you dense. Your breast tissue is dense. So when we see it on mammography, think of dense breast tissue as like fog. It shows up as white, as Dr. Rubinom had said before. So that's where the dense breast ultrasound comes into play. The ultrasound can kind of cut through that fog, that white density of breast tissue that shows up on mammography. We can kind of cut through the fog with that. Tomo has been a great advantage for us as well too, to be able to see things more. But if you ever read your report and you're concerned and it's like, what does that mean? Call somebody, ask some questions. We're always there to help to answer those for you. I do need to put a plug in. We have a lot of women say, I can't afford, I don't have insurance. I can't afford to get a mammogram done. I can't afford to get a clinical breast exam done, a pap smear done, any of those things done. At ECHN, we're very fortunate. We've had a breast and cervical early detection grant with the DPH and the CDC for probably almost 30 years now. So very easy to qualify. It's 250% of the poverty level. We just ask you questions over the phone. We get you qualified. We'll get you scheduled in to see a provider. We'll get your GYN exam done. We'll do that clinical breast exam. We'll pay for that screening mammogram. If something shows up and you need to have a diagnostic mammogram done, which takes additional views of the breast, really targeted at an area of concern, the grant will pay for that as well for you. If you need to see a surgeon, the grant will pay for that as well for you. You need to have a biopsy, the grant will pay that for you as well. So we really are trying to make it very easy for women to get these things done and take care of themselves. So again, no judgment zone, but please, by all means, it is Breast Cancer Awareness Month, but breast cancer awareness is 12 months of the year, not just October. So, please know your body, please speak up. As Dr. Young said, the best thing that we can do tonight is give you information to help empower you.